Thank you so much for the introduction. So today I would be talking about perinatal mental health challenges. So first, I would like to define what a perinatal period is. It is a period that spans from conception or pregnancy through 1 year after childbirth, and it consists of four different phases: the first trimester, second trimester, third trimester for the pregnancy, and then the postpartum phase. Throughout this whole period, women they undergo complex physiological and psychological changes that can adversely affect their and the child's mental health. And these are called as perinatal mood and anxiety disorders. And some of the symptoms of these disorders they include having mood swings, changes in eating or sleeping habits, any kind of harmful thoughts, etc. So, PMAD or perinatal mood and anxiety disorders, they affect about 1 in 4 women in the US. So it is way more common, and they can lead to a $15 billion annual healthcare costs. Also, racial and ethnic disparities they exist in perinatal depression. So, according to a study in California, non-Latina Black women they experienced higher rates of perinatal depression compared to white women, and this disparity is also observed in access to mental health care. Remote intervention systems or systems that can be seen on a mobile phone or a computer, and different types of solutions that include like motivational quotes, virtual assistants, etc. They are promising solutions to access to reduce this perinatal depression and anxiety remotely. However, these current existing systems they target either the pregnancy or the postpartum phase, so they don't target the entire perinatal period. So there is a gap in continuous care. And also, these systems they are rarely designed with the needs of specific cultural, social, structural needs of racial and ethnic groups, and we are focusing primarily on Black or African American women. So, the objective of my research was to inform the development of a remote intervention system by identifying the challenges of Black or African American women experiencing perinatal mood and anxiety disorders, then examining benefits and barriers influencing their use to have such systems, and then determining the key design features and considerations for such remote systems. So, a mixed method research was performed where we first conducted a survey, and 31 women they participated from different perinatal phases, and all of them were screened using the 10-item Edinburgh postnatal depression scale. And all of these women they were then further invited to participate in a 1 hour Zoom interview to share more details about their experiences. So we had 16 participants for the interview. We couldn't get any from the first trimester, but from all the other phases, we were able to get participants. The questions asked in the survey and interview, they were about perinatal mood and anxiety disorder experiences, like what were the different types of challenges they faced, what are their needs, then we talked about the types of they talked about the types of support options that they sought. So it could be in-person support or any kind of remote support or hybrid support, and this was asked for different phases of the perinatal period. Then what were the preferences for these support options, and then what features could be essential for developing a remote intervention system. So again, our target was to span the whole perinatal period, and that's why we had different needs from the pregnancy phase and the postpartum phase. Then, coming to the results of the survey, the primary reasons of PMAD, they were mainly hormonal changes and financial or occupational stress. So they contributed to about 80% of the reason, like 80%. And the other reasons were lack of time for hobbies, no family or partner support, changes of doctors during or after pregnancy. So this was from the survey. And then all of the quantitative survey results, they were analyzed using a one-way ANOVA with perinatal period as the factor, with four different levels. As I mentioned before, first trimester, second trimester, third trimester, and postpartum. So within those results, the frequency of support sought, it was significantly higher for the third trimester compared to first and postpartum, and the preference for remote support that was majorly observed for second and third trimester compared to first and postpartum. Then we also asked them about specific features. So the feature of symptom monitoring that includes monitoring of signals like heart rate for predicting anxiety or depression, and then psychotherapy like cognitive behavioral therapy that had higher preference in the third trimester compared to the first trimester, and then peer support that had a significant preference for second and third trimester compared to the first trimester. Then moving on to the interview results, all of the interview transcripts, they were analyzed using thematic coding. We developed different themes for each of the research questions that I mentioned before. So for the first theme, which is challenges faced, we had four different main themes: emotional challenges, physical challenges, financial challenges, and systemic and social barriers to support. So, coming to the first one, which is emotional challenges, this theme included issues such as fear of unknown pregnancy, feelings of loneliness, mood swings, lack of preparation for pregnancy, etc. And then in the physical challenges, this included body changes that occur during pregnancy or postpartum. So it can be body weight issues, then baby needs, co-occurring health conditions like preeclampsia. And the third theme was financial challenges. So this was about any financial instability because women were supposed to, like, they were not able to work and they had taken some maternal leaves during second and third trimester, and they were afraid that their jobs could be taken. And then any kind of professional responsibility. So this came under financial challenges. And the fourth one, which is systemic and social barriers to support. So this was lack of peer support, lack of family support, lack of mental health support. So women mentioned that there were some times when their healthcare provider, they only cared about their physical health and they did not care about their mental health. So this was another barrier. And then social or cultural stigma to express their PMAD experiences, difficulty scheduling appointments, time constraints to have any kind of support, shyness, rude hospital staff. These were the different challenges. And within them, difficulty scheduling appointments and time constraints, they were like the major factors that were the challenges for support. So the second research question was about the factors that affected their willingness to use remote intervention systems. So we had both benefits and barriers. So as I talked before, difficulty scheduling appointments and time constraints, they were the major barriers, right? And remote intervention systems to some extent can mitigate those barriers because they were more accessible, reliable, they can reduce the travel time as they can be accessed remotely, then they don't have any stigma associated with them as women can just access that remotely in a room, and then they are usually inexpensive. However, some barriers still included time constraints during pregnancy, during postpartum, then the privacy concerns, like women had concerns that their data could be shared anywhere, and then network connectivity issues. Having lack of awareness about such systems, then loss of human connection, and operational difficulties. Like if remote intervention system is very complex technologically, then it will be difficult for them to use such systems. Then the third question was about effective features. So what are the different features that they would like to see in such a system? We have developed this comprehensive list of features. Some of them were more preferred, and we also got this from the survey results. And the four different themes of the features was related to physical health management, access to information, emotional well-being, and some other preferences. So within physical health management, appointment scheduling with healthcare providers, exercise reminders, having some kind of sleep tracking, medication reminders, keeping records of pregnancy progress, these were provided. Then within access to information, women wanted information related to pregnancy, exercise information, nutrition information, which is available online, but sometimes it is not very structured. So if such information is present in the intervention system, they thought that it would be very useful. Then For emotional well-being, they wanted a personalized real-time virtual assistant, journaling feature, peer support, symptom monitoring like analysis of mood and anxiety symptoms, motivational quotes, then some kind of postpartum support. Um, and then they also mention some other features like emergency contact helpline. The remote intervention system should be user friendly. It should have some kind of family involvement and assistance with time management, like having any kind of scheduling calendars. So these are the different list of features that were provided by the women. And within them, the major features that even stood out from the survey were appointment scheduling with healthcare providers, having some type of real-time virtual assistant, then analysis of moods and anxiety symptoms, and motivational goals. So, coming to the discussion, overall, the remote intervention systems, they were found to be accessible. They can reduce stigma that comes from the in-person support. However, they need more awareness. They need robust data protection to mitigate the privacy-related issues, and they need to be user-friendly so that they can be accessible to a lot more women. Also, second and third trimesters, they had a higher preference for remote support compared to the first trimester and postpartum. So those remote intervention systems, they should be considerate about these specific phases as they are critical. Then direct communication with healthcare providers, cognitive therapy, symptom monitoring, and positive quotes was more highly preferred compared to the other features. And finally, flexible scheduling. They mentioned that flexible scheduling should be there, and that should be particularly there in the postpartum period compared to the pregnancy, because in postpartum period, childcare needs, they can actually take up a lot of time for women. And also the intervention timing should be between 15 minutes to an hour. So it should not be too less, it should not be a lot. Then conclusion, overall positive feedback was received for remote support compared to in-person support. And the remote intervention systems should be holistic, where they should include emotional, physical well-being features, information-related features, etc. And we think that perspectives from other racial or ethnic groups in the future would be helpful. One limitation of the study was that women were only asked questions related to a particular time in the perinatal period. So in future, having longitudinal studies that can be conducted to capture the whole perinatal period would be helpful. Yeah. So coming to the acknowledgement, this project was funded by College of Engineering and School of Medicine seed grants, Virginia Tech. And I would like to thank the student assistant Utkarsha Mohan. He helped with thematic coding. And if you have any questions, let me know. Thank you.